My name is Jaime Walters, and I will be going over safe patient handling for caregivers, literature review, and analysis. The research question that will be guiding this review is, does safe patient handling interventions help reduce musculoskeletal injury risk in caregivers? Going over the background, the main overview is manual patient handling causing high risk of musculoskeletal injuries in caregivers. Nurses and CNAs do work one of the most physically demanding jobs that can place stress on the body, causing injuries especially to the back, neck, and shoulders. Nurses do spend most of their shifts walking, standing, and bending, as well as repeatedly repositioning, lifting, and moving patients. This does make nurses highly susceptible to musculoskeletal injuries, which has become a very common problem. This is important because as a nurse constantly lifting and transferring patients, we are not only susceptible to injuring ourselves, but the patients as well. Overexertion and fatigue affected by poor body mechanics can lead to medical errors and increased risk of injury for the nurses and patients. Some knowledge gaps include high workload, understaffing, lack of training, underuse of lift devices and equipment, and a lack of safety culture on the unit. The problem statement is there has been a high prevalence of musculoskeletal injuries in caregivers due to lack of effective implementation and consistency in safe patient handling. Evidence-based journal articles that I have selected are indicated to determine if the interventions for safe patient handling are effective in reducing musculoskeletal injuries among caregivers, including the nurses and CNAs. 17,240 total musculoskeletal disorder cases reported, and the incidence rate was 140.5 per 10,000 workers. The lower back and shoulders were the two most affected areas from the cases reported. Next, for methods, how I conducted this literature search is I used the SPC library database and the PubMed database as well. The terms that I searched included musculoskeletal injuries, caregivers, and safe patient handling. The inclusion criteria included the research studies had to be peer-reviewed, had to be primary quantitative studies that evaluated safe patient handling interventions for caregivers, and the effect that it had on preventing musculoskeletal injuries. And all the studies had to be published within the last 5 years. For the exclusion criteria, this included any secondary source studies, any non-peer-reviewed, and that they were published more than 5 years ago. My search was narrowed down by specifically choosing primary researched articles that were quantitative and not any systematic reviews or meta-analyses. The studies had to include safe patient handling for caregivers and the interventions used to determine if these did help prevent musculoskeletal injuries. So for subject headings, all 3 studies included safe patient handling, musculoskeletal disorders and/or injuries, caregivers, healthcare, and lifting devices. For my research study designs, 1 article was descriptive, 1 is quasi-experimental, and 1 is experimental. So going over the analysis of my first article, Transforming Safety at the Bedside with Safe Patient Handling Practice. This is a quantitative descriptive study. It is level 4 on the hierarchy of research evidence, and the main findings include 50% decrease in workers' compensation claims, 79% reduction in workers' compensation costs, 73% reduction in lost workdays, and 83% reduction in restricted workdays. This is a pre- and post-intervention design without a control group, and it was used to evaluate the effectiveness of safe patient handling programs. The study was based in a level 1 trauma center in New York with bedside nurses, and it was developed for over 3 years. Based on these findings, the Safe Patient Handling Mobility Program reduces musculoskeletal injuries in caregivers significantly. This program helps with the safety of healthcare workers and help with the hospital cost. A vital element in the success of this program is the involvement of the staff to be a part of the building and planning of the Safe Patient Handling Mobility Program. Some gaps in the study did include not having a control group and also that the study was set in only 1 setting. Overall, the results did deem that involving the healthcare staff builds a successful and sustainable safe patient handling mobility program that helps provide a safer environment for both patients and employees by reducing the number of incidences of musculoskeletal injuries. For my second article analysis, evaluation of a passive back support exoskeleton during in-bed patient handling tasks, this is a quantitative experimental study. It is level 3 on the hierarchy of research evidence, and for the main findings, it significantly reduced hip flexion angles on all 4 tasks, significantly reduced lower back muscle activity during the trunk flexion task, did not affect trunk flexion and extension angles on all 4 tasks, and heart rate was not affected at all. This study did involve 8 university students to perform 4 common in-bed patient handling tasks on a simulated patient with and without an exoskeleton on to determine the effectiveness of this intervention on the reduction of musculoskeletal disorders and injuries. The tasks included sitting to lying, repositioning toward the caregiver, turning toward the caregiver, and turning away from the caregiver. There is a picture of the exoskeleton on the screen. It is a wearable robotic device used for ergonomic support to reduce physical strain during physically demanding tasks, such as lifting and repositioning patients. Some gaps in the study included initial friction of the patient against the bed that it could increase the risk of overexertion, and also a caregiver may bend their torso while elevating their arms while repositioning the patient away from them. Also, just the practicality of using an exoskeleton in a real-life hospital setting. The results of this study did indicate that the back support exoskeleton intervention is significantly effective during in-bed patient handling tasks by reducing the biomechanical load on the lower back, and it does require substantial trunk flexion. This helps reduce musculoskeletal injury to caregivers in healthcare settings. This means that this study does support the use of assistive devices for interventions during patient handling tasks to reduce the risk of injury. Further research does need to be done to determine the long-term impact in a hospital setting. For the analysis of my last article, proof of concept testing of safe patient handling intervention using wearable sensor technology, this is a quantitative quasi-experimental study. This is level 3 on the hierarchy of research evidence. And for the main findings in relation to after coaching lifting intervention is the lever arm distance was reduced during horizontal transfers, the spine velocity improved in most movements, and muscle activation was increased in the core and lower body. So this study does use a before and after design to compare the biomechanical risk factors before and after a lifting intervention. The participants were 4 nursing students who wore wearable sensor technology with a motion capture system and muscle activation, who first performed a patient handling task using just standard techniques, and then performed patient handling tasks after the intervention of being coached with a lifting technique. Some gaps in this study does include bias of the participants who could have potentially exaggerated the movements for the study. Another gap was at the small sample size of the collections. The results of this study indicated that the coached lifting intervention technique demonstrated improvements in lever arm distance, trunk velocity, and activation of core muscles while not increasing the risk of injury. Mechanical lifting devices are not always readily available for use, especially during emergency situations. So in conclusion, coach technique lifting interventions can help reduce strain and musculoskeletal injury even without a lifting device. So for synthesis, discussion, and implications, some implications is that the safe patient handling programs and education on lifting techniques and ergonomics help support caregivers in safer care. Interventions including safe patient handling, lifting equipment, exoskeletons, and coaching prevent musculoskeletal injuries in caregivers. With evidence from these studies, healthcare organizations should implement policies for safe patient handling programs by executing mandatory education and training. Based on all 3 studies, these findings suggested that safe patient handling interventions do help reduce the risk of musculoskeletal injury in caregivers, which does improve the safety for both the caregivers and the patient. So for the similarities of all three articles, they all examine the effects that specific interventions had on patient handling. They all supported the outcomes of a reduction of risk for musculoskeletal injuries and outcomes for improved safety, and they emphasized the importance of education and training. The differences between the studies is that all three used different interventions, and all three had different settings. The limitations include further research needing to be done to determine long-term outcomes of these interventions for these studies. Limited access to technologies such as the exoskeleton and wearable monitoring devices can also restrict implementation. And lastly, participant bias is another limitation in Articles 2 and 3, since these were not conducted in real clinical settings and they were set in controlled environments using simulation. And lastly, for conclusion, healthcare workers continue to experience one of the highest rates of musculoskeletal injuries in the U.S. There is consistent evidence with all three studies that show that safe patient handling interventions, such as safe patient handling programs, exoskeleton technologies, and wearable sensor systems and coaching interventions, enhance patient and caregiver safety and reduces the risk of the musculoskeletal injuries. All three studies do highlight the need for more research to be done to determine long-term and sustained outcomes. For my recommendations is to evaluate long-term outcomes and effectiveness of the interventions that are introduced. Larger and longer studies need to be made over a long period of time, conducted across multiple settings and environments. For my second recommendation, future research should implement these interventions of these studies in real-world hospital settings rather than in simulation-based environments to determine their effectiveness and practicality.